This special episode of New Retina Radio is supported by Genentech, which is responsible for its content. Hello, listeners, and welcome to the podcast. Today, we are going to talk about the development of an innovative drug delivery system for treating neovascular AMD. Our guests today are two retinal physicians that have truly changed the way we think and do things in our field. First, we have Dr. Tony Adamis. Tony, welcome to the podcast.
Hey, John, for the too kind introduction. Great to be with you.
Absolutely. And Dr. Adamis, I would tell you, you're the Eugene de Juan of anti-VEGF therapy, and that gives me great pleasure to introduce the Tony Adamis of surgical retina, someone who I've looked up to for 25 years, Dr. Eugene de Juan. Gene, welcome to the podcast.
Thank you, John, and happy to be here, especially with Tony.
Well, let's start a little bit, though, talking about your careers and following your careers. Tony, I'd like to start with you. Kind of give us a walk through your history. How did you end up where you're at?
I spent 12 years at Genentech. And I got to tell you, when I started out my career in ophthalmology, never thought I would work in the industry. But all of us who are physicians are problem solvers. And I very much enjoyed research and the problems that it posed and how we could potentially solve those problems to help patients. So when I was starting my academic career and we discovered what VEGF could do in eye disease, and this was with Napoleon Ferrara, who was a young scientist at the time at Genentech, who actually discovered VEGF, characterized it, and cloned the gene. I called him up, and we did the initial experiments, and over the course of a decade, with a group of people I was working with at Harvard, Joan Miller and Lloyd Aiello and others, it became clear VEGF was a great target. But you can't develop drugs in academia. You don't have the resources and the scale to do it. So I had to jump over to industry, first to high-tech and then later to Genentech, Roche.
And Tony, certainly your role in the development of VEGF and VEGF inhibition actually has just been so instrumental in everything that we do. Did you have any idea that it would be so important in eye diseases?
No, you don't know. We did the initial animal experiments. It worked really well. The early patients we treated, there were clear signs of bioactivity. But no, we didn't know the impact it would have.
Was it a difficult transition to leave academia and go into industry?
Yeah, I loved seeing patients. I loved everything that I was doing as a practicing ophthalmologist. But I also was hooked by the impact one could have. By that, I mean the scale. So treating patients as a clinician, it's a one-on-one enterprise. But if we got our science right in industry, the drugs that we develop could affect many more patients. So for me, that was always a great motivator.
Gene, I'd love to move on to you. For everything that Tony's done in the medical world, you've really kind of done an equivalent amount in the surgical world. Tell me how you got started.
I'm from Mobile, Alabama. My father's ophthalmologist, and so I thought the greatest thing in the world would be being a doctor and being a private practice ophthalmologist. I didn't have a vision for more. My dad very early on said, when I was trying to say where I wanted to be a scientist, I always loved science, I'd be a doctor. He said, well, a doctor can do the same thing as a scientist, except the doctor gets paid more. So at 12, I decided I'd be a doctor. And so just kind of fast forward, and I remember in medical school, he said, you ought to work with this guy named Mockimer, who was, and so before I knew where I wanted to go for ophthalmology, I knew I wanted to work with this guy named Mockimer, and I ended up being able to at Duke and, learn from him how to kind of innovate around surgical things. I mean, fluid gas exchange, and crazy things, laser. He and a bunch of people were there. So kind of like Tony, being at the mecca for neovascularization and understanding of that biology and all those wonderful people up there, being with Mockimer was for really innovative. Then I moved back to Hopkins. I trained at Hopkins and went back to Hopkins and started the Mad Lab. And there was this guy, Peter Cappuccero, who was more on the biology side than the instrument side, and said, we need some better ways of delivering drugs to the back of the eye. And I said, okay, we can do that. And so we just kind of thought about it, and very early on, that was one of the first concepts of how to get drugs to the back of the eyes. So I certainly am proud of it, and proud of working with Tony and Genentech.
And speaking of that relationship with Tony, do you all each remember the first time you met, and what was that like?
Tony, you want to go or you want me to go? It's a long time ago. We were kind of old, so it's hard to,
Yeah, Gene, I got to tell you the truth. I don't remember when I first met you, but I remember reading your stuff and just being amazed by the out-of-the-box ideas you were coming up with.
Yeah, I was always very respectful of Tony. I think we really have, huge mutual respect, and I think that was a key piece of us being able to work together. From that moment, we can't remember when it was, but from that time, I knew, and I think even Tony knew that we wanted to work together.
Yeah, I think that's true.
So, Gene, question for you. Are you a surgeon that became an inventor, or an inventor that really became a surgeon?
I don't know really how to answer that, but I wanted to be famous. I looked in the World Book Encyclopedia. Nobody knows what that is because nobody needs to. We have Wikipedia. And in the World Book, there was no De Juan. And I figured, through the millennia, that there was no single person that either did anything so bad or so good that they would get stuck into the World Book. And so I said, well, how would I be famous? And I thought, well, there are all these Spanish ophthalmologists like Castro Viejo and Aruga and all that. And I said, maybe I'd make an instrument. That would be a really good way to leave the world a better place. And so I was fascinated by the name, the naming of instruments by the surgeon's name. And so as a resident, I made an iris retractor that for retina. But then, working with Mockimer, after 3 months there, he asked me to stay on as a faculty member, as a fellow, and that really changed my life. Gave me a view of that if you thought of a better way, you could make it happen.
We're here today to talk about neovascular AMD. The American Society of Retina Specialists 22nd Annual Preferences and Trends Survey, or PAT survey for 2020, discussed here with their permission, found that the top 2 unmet needs for retina specialists are how to reduce treatment burden and ensure long-acting sustainable delivery. Additional unmet needs included developing new treatment mechanisms of action, improving efficacy, and improved safety. We are going to be talking about Susvimo and the development of a new drug delivery system for neovascular AMD.
Susvimo, ranibizumab injection, is indicated for the treatment of patients with neovascular or wet age-related macular degeneration who have previously responded to at least 2 intravitreal injections of a vascular endothelial growth factor or VEGF inhibitor medication. The Susvimo implant has been associated with a 3-fold higher rate of endophthalmitis than monthly intravitreal injections of ranibizumab. Many of these events were associated with conjunctival retractions or erosions. Appropriate conjunctiva management and early detection with surgical repair of conjunctival retractions or erosions may reduce the risk of endophthalmitis. In clinical trials, 2% of patients receiving a ranibizumab implant experienced at least one episode of endophthalmitis.
Susvimo is an intraocular long-acting port delivery system that enables continuous delivery of ranibizumab into the vitreous. As a refillable implant, Susvimo is surgically placed in the vitreous in an outpatient surgical center, and refills are performed as an in-office procedure approximately every 6 months. Susvimo dispenses a customized formulation of ranibizumab over time through passive diffusion down a concentration gradient into the vitreous cavity according to Fick's law. The delivery system includes a porous metal release control element specifically designed for ranibizumab, which allows for controlled, continuous delivery of the drug over time. Now let's turn our attention to the treatment landscape and challenges of treating neovascular AMD. Tony, can you tell us a little bit about your perspectives on the evolution of the treatment landscape?
Well, it's like what Gene was talking about, where he and Peter were talking early on about new ways of getting drugs to the back of the eye. We were working in Boston with the Draper Lab at MIT on some early ideas along the same lines. But, what we saw with the phase 3 anti-VEGF trials was how effective frequent injections were at preventing people from losing vision. But as the real-world data came out, it was apparent that we weren't replicating those phase 3 results across multiple drugs. So the other piece of data that was really important was that the outcomes in the real world correlated with the number of injections. The more injections you had, the better the outcomes. And I think the field sensed this as well. So in the latest ASRS PAD survey, the two things the field has called out is a reduction in treatment burden and a need for long-acting delivery. So I think everybody started to coalesce around this idea that we needed long-acting delivery to the retina. And that's something Gene's been working on for decades, and I've been working on for decades. But it was when I saw what Gene was working on that it was kind of an aha moment.
So, Gene, take us back to that early development of Susvimo. Was it designed with anti-VEGF therapy in mind, or did you have a different concept when you first thought of it?
Well, when we first had the idea of a reservoir, it was a general idea. We didn't have a drug. But later, when it became, it became obvious that the use of anti-VEGFs was going to be huge and the treatments were going to be frequent, then the need went way up for something that addressed that. And so, we had a general concept, but we didn't have a concept with how things like how stable would an anti-VEGF be at 37 degrees, how much would you need every day leaking out, what's going to prevent it from getting clogged or aggregation. And so all of those things we began to address, and we had some, there was a guy named Kerry Reich who came up with the control release element, the thing that controls the release, and that was, it's very straightforward, but it was a genius observation, and it really made it happen. We tested both to just find the lower limit of that, and that was that really what led us the need, and then kind of a team of people that really knew how to, put together a tiny little reservoir, and I did take credit for the idea of putting it in, that it's kind of it's got this kind of hourglass shape that kind of holds it into place without a suture, and so that kind of thoughts came from the surgical side, but a lot of the other was just really smart engineers and scientists to come up with something very, very simple. And frankly, when I showed it to Tony, and I think that this was a thing that the scientists might not get right off the bat. But Tony, as an operating surgeon, understood immediately how that would work and that it would be tolerable. And so that was, it's not easy. That's still, nothing's ever perfect, but that is, Tony was able to see that really, at the very, very beginning. And it was, and he made that happen. If we'd been on our own, we couldn't have made it happen. We needed the drug to deliver. Without the drug, we didn't, it's nothing.
And the elegance of it is what really got me. It's solid state, but the size of a grain of rice. It's implanted in a pars plana. We do this. Our field has implanted devices in that space. It works based on just the drug going down its diffusion gradient and that release control element, the physics of it, Fick's law, the diffusion length of the release control element, the tortuosity of it, all those things make it tunable. So you can tune exactly how quickly it'll release based on the initial concentration.
And Gene, were there a lot of revisions to this as it became more and more targeted towards ranibizumab and wet age-related macular degeneration, or was it just a few tweaks that got it up and running?
I don't know, a few tweaks, but the first ones were made kind of by hand and by machining, and they were made out of IOL material, PMMA, and so we knew that would be stable, and we had different structure, but it looks more or less the same. The first clinical, the phase one, the first ones that we first did looked basically identical. It's a different material, the different ways of securing parts of the device component, and but there were lots of iterations and lots of discussions of how to manufacture it on scale.
Just to add a little context, John, this collaboration started in 2010. So, we're filming this in 2021. Gene had already done a few patients, but working with his team, we redesigned it, the materials, coming up with, the needle that allows the refilling. All that took time, as well as the clinical development, going and doing ladder and then later archway. So drug development, or in this case, drug device development, takes a while.
Tony, you mentioned the refill needle. Gene, I want to come to you about that. Did you design the refill needle?
I did not design it. I mean, there was a group of us there. Randy Campbell, Signa Erickson, that were involved in that. We were initially just flushing the device with a fresh amount of fluid, so we would overfill, and half would go into the eye and half would stay in the device. But it became clear that we wanted not to do that because we had a much higher concentration, so we wanted to aspirate and at the same time as inject. And how much do you have to do that to fill it precisely? The other thing about that, obviously, is that now you can measure very precisely also the elements that are released inside the eye also go back up into the device. And so you can actually interrogate what's going on inside the eye through this refill capture thing. So that was fun. And I think it'll end up being a very interesting way that we can interrogate the eye much differently than we ever have before.
How did we figure out the exact dosing that we use with Susvimo?
So we have a fantastic modeling group at Genentech, and they came up with 3 doses that we took into phase 2 into the latter trial, and compared that to monthly ranibizumab, and selected the dose that we thought had the best durability and efficacy, and that's what we took forward into phase 3. So it was in that sense, it was a classic development program, dose ranging in phase 2. So we learned a lot about the surgical procedure in addition to the dose, how to best implant this as safely as possible. So there were modifications to the surgical procedure. So that, along with the dose and the 6-month interval, those were all taken forward into Archway.
So the primary endpoint in the Archway study was the change from baseline best corrected acuity score averaged over week 36 and week 40. Patients with Susvimo achieved visual acuity gains equivalent to monthly ranibizumab injections. And as was mentioned earlier in the podcast, Susvimo has a boxed warning regarding endophthalmitis. The Susvimo implant has been associated with a 3-fold higher rate of endophthalmitis than monthly intravitreal injections of ranibizumab. The most common ocular adverse reactions during the postoperative period were conjunctival hemorrhage, conjunctival hyperemia, iritis, and eye pain.
So then, John, after Archway was underway and was conducted by all the people who were involved in this, both at Genentech and all our investigators, we were very grateful to get the final results. Right, that led to the approval. This was an FDA approval based on the results of Archway, together with Ladder before it, which is a randomized multi-center open label phase 3 study that evaluated the safety and efficacy of Susvimo. And, you don't get many FDA approvals in a career, but when you get them, it's burned in your memory.
Gene, obviously, surgical products, be it small gauge vitrectomy or Susvimo, obviously you're going to have some hurdles and obstacles. How does that go from just thinking, aha, I've got this idea, to then actually developing something?
Yeah, so that's a really good question, John. Here is, I had this idea a few years ago at Hopkins. Now I'm up in the Bay Area at Foresight with a team that has done a lot of development. And we're working on another project. And I say, we really, as a retina guy, we really need this. We just cannot sustain the effort. And it's just not the way to do it. We really can do this, and we can do it. And so I'm talking to the team, and they're all, running hard, and their tongues are out, and they're busy. And so starting something new is always a challenge. It's always on top of what you're doing. And Yair Alster and Angela McFarland, we said, well, let's start. Let's just start doing this. And we started playing with how little amount of anti-VEGF. We went down to Mexico and started learning that. And we realized that we could, this is possible. And we got some funding from 3 venture groups that are typically funded us. And we had some early resources, and we had some early engineering support and thoughts. And Kerry Reich, came up with this idea, going to not a medical meeting, but a kind of a supplier meeting that realized that this would be a good way of controlling it. And so it's just the pieces go together. The need always is the need that drives it. And then if there's a need, and we think about it, we can go and try to solve that need with every resource we got. And that's what I really love to do, John. That kind of what you're saying is, if we got a problem, let's go and fix it. And this one, we were absolutely dependent on Genentech. We knew that we had solved kind of the problem, but we didn't have rights to the drug. We could not have done this without Tony and the support of Genentech. And I think you just can't understand how big we could solve the problem, which together we have, but we couldn't have done it alone. I'm deeply appreciative, not just personally, but, for our field and for the patients.
And Tony, similarly, you are coming at it from the molecular side, from the anti-VEGF side. Did you know immediately this is it, or were you kind of canvassing a lot of different concepts, and this just happened to be the one that worked out?
We had a bunch going in parallel. And I got to tell you, in all honesty, when I was handicapping them, there were others ahead of it. But it just goes to show the unpredictability of it. Development is you have to go through it because nobody knows the answers a priori, right? It's an iterative process. There are always going to be issues and hiccups and near-death experiences. We didn't want to reinvent the wheel. So I said to the team, there are device companies out there. There are, stents. There are artificial hips. There are surgeons around the world constantly being trained on new procedures. Let's learn what the best practices are there and adapt them and adopt them to our clinical trials that we're doing going forward. And we even did some innovative stuff that people thought of, like, the virtual reality workstations that help people practice before they got into the OR. So it was a steep learning curve for us as well. Genentech hadn't done a device like this before in ophthalmology and really in all of our therapeutic areas. But it was a lot of fun. Steep learning curves are steep, but they're fun. As Gene said, the team, and we're just here representing a very large group of people, the team put their heads together, including some of our investigators, Jay Stewart at UCSF, Giulio Barticelli, solve major issues, Jill Hopkins, Yawen Chang would sleep in her cot in her office Monday through Friday, helping to solve issues. There's so many untold stories behind the scenes. But, we are problem solvers. As I said at the beginning, as surgeons and as physicians, we have an affinity for this. And we worked the problem. We didn't panic. We worked the problem and got through it. And, so we could get to the point where we are today. And it would not happen without Gene and his group. It really was a true collaboration all the way through.
And Tony, now you've seen this from the amazing development of anti-VEGF therapy now to a way that we can have an extended release of an anti-VEGF therapy that can give 6-month dosing. What's next for you?
Retirement, but no, I'm kidding. I'm lucky I get paid to do my hobby. I love doing this, and I think I speak for Gene as well. We're in a wonderful field. It's a small, close-knit community. I think of where retina was 30 years ago and where we are today. I just want to keep doing this in some sort of manner. Still to be determined because it's only week 6 of retirement.
And what a way to end your career, at least from the Genentech Roche side of things, with this development. And Gene, for you with Foresight, what's next?
We are, I'm really dedicated to solving these problems, big problems. We have efforts going on and AMD. I'd love to cure that disease. Tony and I have talked about that too in the past, and glaucoma, RP. And so I just want to, I'd really, I talk about if I do that, then I can go to the beach, and visit Tony.
It absolutely wouldn't surprise me a bit if you guys can't make that happen, in all honesty. It's been such an amazing opportunity to talk to 2 luminaries in our field, Dr. Tony Adamis, Dr. Eugene de Juan. Both of you have been responsible for the development of Susvimo, and I just want to point out we're going to have two other podcasts talking about Susvimo. The first is going to be perspectives on an innovative drug delivery system for neovascular AMD, from training to initial experiences. And in this podcast, we're going to really discuss the experiences of two great retinal surgeons learning the surgery and refill exchange procedure for Susvimo. In the other podcast, which is titled Exploring the Clinical Development Program for an Innovative Continuous Delivery Treatment for Neovascular AMD, we'll cover the experience of one of the investigators in the clinical trials. We really hope you'll be able to tune into these podcasts as well. And I want to thank you all for joining us. Please listen carefully to the following important safety information.
Susvimo is contraindicated in patients with ocular or periocular infections, active intraocular inflammation, or hypersensitivity to ranibizumab products or any of the excipients in Susvimo. The Susvimo implant and/or implant-related procedures have been associated with endophthalmitis, rhegmatogenous retinal detachment, implant dislocation, septum dislodgement, vitreous hemorrhage, conjunctival erosion, conjunctival retraction, and conjunctival blebs. Patients should be instructed to report any signs or symptoms that could be associated with these events without delay. In some cases, these events can present asymptomatically. The implant and the tissue overlying the implant flange should be monitored routinely following the implant insertion and refill exchange procedures to permit early medical or surgical intervention as necessary. Special precautions need to be taken when handling Susvimo components. In the active comparator period of controlled clinical trials, the ranibizumab implant has been associated with a 3-fold higher rate of endophthalmitis than monthly intravitreal injections of ranibizumab, 1.7% in the Susvimo arm versus 0.5% in the intravitreal arm. When including extension phases of clinical trials, 2% or 11 of 555 of patients receiving the ranibizumab implant experienced an episode of endophthalmitis. Reports occurred between day 5 and day 853, with the median of day 173. Many, but not all, of the cases of endophthalmitis reported a preceding or concurrent conjunctival retraction or erosion event. Endophthalmitis should be treated promptly in an effort to reduce the risk of vision loss and maximize recovery. The Susvimo dose or refill exchange should be delayed until resolution of endophthalmitis. Patients should not have an active or suspected ocular or periocular infection or severe systemic infection at the time of any Susvimo implant or refill procedure. Appropriate intraoperative handling followed by secure closure of the conjunctiva and Tenon's capsule and early detection and surgical repair of conjunctival erosions or retractions may reduce the risk of endophthalmitis. Rhegmatogenous retinal detachments have occurred in clinical trials of Susvimo and may result in vision loss. Rhegmatogenous retinal detachments should be promptly treated with an intervention, for example, pneumatic retinopexy, vitrectomy, or laser photocoagulation. The Susvimo dose or refill exchange should be delayed in the presence of a retinal detachment or retinal break. Careful evaluation of the retinal periphery is recommended to be performed, and any suspected areas of abnormal vitreoretinal adhesion or retinal breaks should be treated before inserting the implant in the eye. In clinical trials, the device dislocated or subluxated into the vitreous cavity or extended outside the vitreous cavity into or beyond the subconjunctival space. Device dislocation requires urgent surgical intervention. Strict adherence to the scleral incision length and appropriate targeting of the pars plana during laser ablation may reduce the risk of implant dislocation. In clinical trials, a type of implant damage where the septum has dislodged into the implant body has been reported. Perform a dilated slit lamp exam and/or dilated indirect ophthalmoscopy to inspect the implant in the vitreous cavity through the pupil prior to and after the refill exchange procedure to identify if septum dislodgement has occurred. Discontinue treatment with Susvimo following septum dislodgement and consider implant removal should the benefit of the removal procedure outweigh the risk. Appropriate handling and insertion of the refill needle into the septum, while avoiding any twisting and/or rotation, is required to minimize the risk of septum dislodgement. Vitreous hemorrhages may result in temporary vision loss. Vitrectomy may be needed in the case of non-clearing vitreous hemorrhage. In clinical trials of Susvimo, including extension phases, vitreous hemorrhages were reported in 5.2%, or 23 of 443 of patients receiving Susvimo. The majority of these hemorrhages occurred within the first postoperative month following surgical implantation, and the majority of vitreous hemorrhages resolved spontaneously. Patients on antithrombotic medication, for example, oral anticoagulants, aspirin, nonsteroidal anti-inflammatory drugs, may be at increased risk of vitreous hemorrhage. Antithrombotic medications are recommended to be temporarily interrupted prior to the implant insertion procedure. The Susvimo dose or refill exchange should be delayed in the event of sight-threatening vitreous hemorrhage. The use of pars plana laser ablation and scleral cauterization should be performed to reduce the risk of vitreous hemorrhage. A conjunctival erosion is a full-thickness degradation or breakdown of the conjunctiva in the area of the implant flange. A conjunctival retraction is a recession or opening of the limbal and/or radial peritomy. Conjunctival erosions or retractions have been associated with an increased risk of endophthalmitis, especially if the implant becomes exposed. Surgical intervention, for example, conjunctival or Tenon's capsule repair, is recommended to be performed in cases of conjunctival erosion or retraction with or without exposure of the implant flange. In clinical trials of Susvimo, including extension phases, 3.6%, or 16 of 443 of patients receiving Susvimo reported conjunctival erosion in 1.6%, or 7 of 443 of patients receiving Susvimo reported conjunctival retraction in the study eye. Appropriate intraoperative handling of the conjunctiva and Tenon's capsule to preserve tissue integrity and secure closure of peritomy while ensuring placement of sutures away from implant edge may reduce the risk of conjunctival erosion or retraction. The implant and the tissue overlying the implant flange should be monitored routinely following the implant insertion. A conjunctival bleb is an encapsulated elevation of the conjunctiva above the implant flange, which may be secondary to subconjunctival thickening or fluid. Conjunctival blebs may require surgical management to avoid further complications, especially if the implant septum is no longer identifiable due to the conjunctival bleb. In clinical trials of Susvimo, including extension phases, 5.9%, or 26 of 443 of patients receiving Susvimo reported conjunctival bleb or conjunctival filtering bleb leak in the study eye. Strict adherence to the scleral incision length, appropriate intraoperative handling of the conjunctiva and Tenon's capsule to preserve tissue integrity and secure closure of peritomy, and proper seating of the refill needle during refill exchange procedures may reduce the risk of conjunctival bleb. Visual acuity was decreased by an average of 4 letters in the first postoperative month and an average of 2 letters in the second postoperative month following initial implantation of Susvimo. Minimize air bubbles within the implant reservoir as they may cause slower drug release. During the initial fill procedure, if an air bubble is present, it must be no larger than 1/3 of the widest diameter of the implant. If excess air is observed after initial fill, do not use the implant. During the refill exchange procedure, if excess air is present in the syringe and needle, do not use the syringe and needle. If excess air bubbles are observed after the refill exchange procedure, consider repeating the refill exchange procedure. Use caution when performing ophthalmic procedures that may cause deflection of the implant and subsequent injury. For example, B-scan ophthalmic ultrasound, scleral depression, or gonioscopy. In the neovascular AMD archway study following the Susvimo initial fill and implant insertion, refill, and implant removal, if necessary, procedures up to the week 40, the most common, or greater than or equal to 10%, Adverse reactions up to week 40 were conjunctival hemorrhage in 72%, conjunctival hyperemia in 26%, iritis in 23%, and eye pain in 10%. Females of reproductive potential should use effective contraception during treatment with Susvimo and for at least 12 months after the last dose of Susvimo. No studies on the effects of ranibizumab on fertility have been conducted, and it is not known whether ranibizumab can affect reproduction capacity. Based on the anti-VEGF mechanism of action for ranibizumab, treatment with Susvimo may pose a risk to reproductive capacity. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555. Please see additional important safety information in the full Susvimo prescribing information, including boxed warning.